So we're gonna go over kind of you guys can eat as we go, right? Okay. So we're gonna go over airway management, kind of from a soup to nuts perspective. Start with the basics, build off of that. We're gonna start with the fundamentals and then get into more invasive airway management. So the objectives are going to be the review the fundamentals, and then we're going to go over acquiring the desirable view, positioning methods, and then laryngoscopy methods. So there's more than one. Really pick the one that works for you. There is no, this is the way that you must do it. There's multiple ways you can do it, but find what works for you and then stick with it. It's kind of the recommendation. We're going to review BLS, airway methods, and then we're going to understand laryngoscopy, determine the use of video versus direct, because there's both goals with different methods of intubation, and then how to get the appropriate glottic view, kind of epiglottoscopy is what they're calling it these days. So start with the BLS review, and start with the head first. Don't worry about your BVM, don't worry about your other airways, get your head in a good position. Head tilt, chin lift, jaw thrust, every single time. There's no reason to not do these BLS simple maneuvers every single time you're managing an airway. Too many times I see it, we go into a cardiac arrest scenario, the face is flat to the ceiling, we're not in a good sniffing position or head tilt chin lift, the airway is still closed. Open the airway every single time. Even if your patient's semi-responsive, struggling to breathe, just go over and pick their chin up a little bit, tilt their head back a little bit, just open the airway. And then we're going to ensure patency, so suction anything visible in the airway. This is before you place your OPA or NPA. Because think about the worst airway you've seen. It's full of vomitus, full of that cream of mushroom soup. It's just a disgusting airway. You take your OPA, you put that OPA in, squeeze that bag, and what happens?
Put it in the lungs.
Nothing. Nothing happens. It's not good. So you have to suction the airway first. Just get in the habit of prepping your suction every single time, suction the airway out, and don't use those crappy yank hour suctions. I am. Don't use those like horrible yank hour catheters. Those are designed for like pure fluid. Get one of those like wide bore decantos. We have them for a reason. They're meant for suctioning the stuff that EMS sees. Just use them. Don't even bother with that yank hour. It's not designed for what we suction. Then place your OPA or NPA. And use a good CE grip if you're by yourself. But you've got a partner, we've got firefighters. Use a two-person BVM technique. And in the difficult airway course, they call it like the T method, where instead of having a C, you put your thumbs flat towards the patient's feet and hold the mask flat with your thumbs down. And it's much more effective to maintain that seal. And we're not squeezing the whole damn BVM, just a quarter squeeze. Those things are honestly full of 1,600 milliliters of air. Almost a 2-liter soda bottle. That's quite a bit. Our goal is 400. After that, we're going to optimize oxygenation. Attach a PEEP valve. Attach it to O2. We always forget to attach to O2 in that code setting. And then you can always add an additional nasal cannula. And this isn't your Untitled cannula. This is a regular cannula out of the box, out of the compartment, out of your O2 bag, because if we're going to go to intubate, that platypus is going to get in your way. That extra Untitled cannula piece is just going to get in your way. You won't be able to do what you have to do with that airway. Get rid of that thing. Just use a regular cannula. Our metrics, however, we're going to put CO2 in line. We're going to attach pulse oximetry. And then determine your airway compliance. Can you squeeze that bag, or is it like trying to bag into concrete? If it's like bagging into concrete, reposition your airway, suction. You can go further down, not a big deal. Suction all that gunk out of that airway. If you're still having bad compliance, now is when we're going to be considering intubation or a supraglottic airway. Intubation is the gold standard. We should be attempting to intubate these patients on cardiac arrests, or your patient goes unconscious on you, because while the studies do say that iGels and King Airways have the same aspiration protection as an ET tube, we know they don't. We just got boluses of shit in that airway, and we got to fix it. So intubate them at this point is when you'd make that decision, versus if you got good BVM ventilation, you don't necessarily have to intubate. But we're also going to have to ensure a certain minute ventilation. We have to meet 4 to 8 liters per minute of minute ventilation just to maintain homeostasis. Adequate FiO2, so if your pulse ox is low, increase the oxygen. And then good rate and good volume, so 12 to 20, somewhere in that range, 12 to 16. Volumes are about quarter of a bag squeeze. We don't want to overinflate their lungs. Time to intubate. So decreased compliance is going to be one of the mechanisms. The others, you can't ventilate. You try and squeeze that bag and it's going nowhere. You can't get air in the lungs. You don't get that chest rise. You have to secure the airway, so they're vomiting consistently. Their airway is full of blood, vomitous secretions. So it gives us better control of the oxygenation ventilatory status. And we can use a mechanical ventilator. You can't use a mechanical ventilator non-intubated. We have to have either a King LT, an iGel, an LMA, or an ET tube to use the mechanical ventilator, which can really we can get pretty precise with our oxygenation status, our ventilation status. We get real good control with that mechanical vent that we can't get with a BVM. Our hands aren't that precise. So step 1 is always going to be preparation. And we should have all of these things laid out for every single intubation. And this is something non-medics can prepare. So if we're thinking about intubation, get the suction ready, set it by the head. Pull out the laryngoscope, pull out a bougie. Every intubation, unless you're 100% success on intubating, use a bougie. Makes it so much easier. And if you're going in with a Stylette anyway, bougies are secondary. So if you can't get it, go to a bougie. Always have that bougie ready. Have Stylettes ready. If you're going with a bougie and you can't angle it correctly, you may need to use a Stylette in that tube instead. Have tube sizes. Have at least for adults a 7.0 and a 7.5 out. 10 cc syringe. We all forget this. Set it out. Have it ready. Have your securing device ready and available. Next, have your biad or your backup airway ready, your supraglottic airway. And then, clearly, your BVM. And just remember that your BVM does pop off with that face mask. You already have end tidal in line, so all you have to do at this point, if you've been doing good BLS airway maneuvers, is pull that face mask off because the end tidal is already on there. We're already capturing that metric. Now you've got to pick your poison. Are you going to go video or are you going to go direct? How do you know? Well, we're going to use the Heaven criteria. And the Heaven criteria, we used to use lemon and Mallampati for predicting difficult airways. Heaven's the new lemon. So H is for hypoxia. So we've got O2 sats below 93%. We've got E for extremes of size. This is both pediatrics and large bariatrics. A is our anatomic challenges. So we have masses, we've got large goiters, short, thick necks, long, elongated necks, anything that makes it going to be difficult to intubate. They've got this large Adam's apple that makes us think they have a very anterior airway. Would be an anatomic challenge.
People with Downs?
Absolutely. People that have chromosomal disorders. They've got big tongues. They can have a lot of other issues, so we may need to be thinking about that as well. Any vomit, blood, or fluid. If we're using video, that vomit, blood, or fluid, well, that's going to cover that camera with gunk, and now we can't see shit on the screen. So we should probably go direct in that case versus video. Any exsanguination, so we're thinking they're very high risk for decompensation. They've got their bleeding somewhere, either internally, externally. We need to rapidly intubate this person. And then neck, so short fat necks, long skinny necks, cervical collars in place, neck mobility, anything that's going to impair our ability to manipulate that neck into a good position. So how do we determine VL versus DL? Well, direct should probably be with hypoxemia, exsanguination, and vomiting and secretions. So these three criteria require speed. They require rapid intubation, and direct is always faster than video. If you can get a good view, direct facilitates faster intubation than video. So hypoxemia, we need to rapidly pre-oxygenate and then rapidly intubate. You don't want to be sitting on the airway just waiting. Exsanguination, again, rapid decompensation. We need to intubate them rapidly. And then vomit and secretions, it's going to gunk up your camera. So if you're suctioning on the way in with a bulb, you might not be able to see everything, but you can see more than a gunked up camera. Indications for video would be size extremes, so bariatric and pediatric. Any anatomic challenges, video is going to provide a better view. And then with decreased neck mobility, we have the hyperangulated blades to allow for less neck manipulation to still get a view of the glottic opening. So find out what works and do what works. If you're going to try something new, keep trying it, practice with it, and stick with it. But ultimately have a method that works and use the method that works. Positioning. This is one of our first P's. Position the head the right way. So we have our three angles. We have our oral angle, which goes along the hard palate straight into the back of the throat. It's that view you see when you open your mouth. That's what you see.
30 minutes. Basic. Cardiac.
Then we have our pharyngeal angle, and that's the view along the back of the throat. That's straight down the back of the throat. And then our laryngeal angle is the angle it takes to see the vocal cords. So by doing a head tilt chin lift sniffing position with head elevation by about 2, 3, 4 inches, now we can actually align those angles. And what we're trying to do is trying to manipulate this tissue right here so that now we have a straight line. We've got 3 straight lines. So if we just look at our airway, what angle is this? If you look at the oral angle compared to the laryngeal angle, it's a 90-degree corner. It's basically a 90-degree corner. And we need to somehow make that into a straight line. So we're going to displace this tissue up and away to make that into a straight line. That's the goal. Is that we're looking here and we need to be able to see the larynx. Ramp them. So the first picture on the left is as if they're on the stretcher. So elevate that head of the bed. Use our stretcher to elevate them up if they're on there. If they're on the floor in cardiac arrest, take blankets, sheets, patient's pillows, ramp the back, and what we're going for is the ear to sternal notch. And by going ear to sternal notch, that gives us the optimum position of view. That aligns everything, puts it all in the right place, so we can make that right angle now into a straight line. Position yourself. So if you look at picture 1, figure 1, she's crouched down, slumped over. She can't really see anything. Pull back, come from the back, straight arm, straight back, don't be scrunched up. Everything in this picture over here, she's using her shoulder. Over here, she's using her entire body to lift up and away. And also get yourself in the right mindset. Position your mind that you're going to succeed. If you go in thinking you're not going to succeed, you're probably not going to succeed. So we're going to start with this term called Epiglottoscopy, which is kind of coined by Dr. Levitan. And what he says is that if you look at this airway here, where does the epiglottis exist? And where will it be on every single patient? If you're an ant and you're walking down the tongue, going to the sugar, every single time you'll run into epiglottis. So why do we just put the blade in all the way and pull it back? It works sometimes, but if you start at the tip of the tongue and you progressively walk down the tongue, every single time you will run into the epiglottis, without a doubt. Epiglottis comes first. So if you can't view the epiglottis, you're not going to get the tube, because what lies directly beneath the epiglottis? Vocal cords. The laryngeal opening, the glottic opening, is directly below the epiglottis every single time. So find the epiglottis, and you know that our destination, the place that we want to be, is always directly below the epiglottis. So find the epiglottis, and now we know exactly where to go. So we're going to suction the oral pharynx, suction all that crap out of our way so we can see what we're doing. And then put that suction further down. And the blade's going to follow the tongue. And the blade also follows the suction. So suction first, then blade. Suction first, then blade. Always advancing one at a time, almost stair-stepping down the tongue until you find the destination, which is, in this case, the epiglottis first. And then directly behind the epiglottis is our vocal cords, our glottic opening. So as we go in, we get our first view, is that. Looking at these structures, the first thing that we see are the corniculate cartilage here and the cuneiform cartilages. Those are the first things we see. You don't see much besides that. And you'll see an epiglottis. That's about all you can see. So we lift a little bit more, and now we start seeing vocal cords. You see the glottis. And then we lift even further, and now we see epiglottis up here, and we get a full view. And this is the traditional view that we're all taught to look for right here. But in reality, this bottom third is all you're probably going to see at first, and that's enough. That's enough to know if you can identify these cartilages here, the corniculate cartilage and the cuneiform cartilage. That's only one place, that's one hole. That's the trachea. So we're going to go there. The vocal cords are always underneath the epiglottis. This is like, stick this in your brain, hold on to it, love this. Like, under the epiglottis is always the vocal cords. So if all you can see is epiglottis, take that bougie, under the epiglottis, shove it there. That's where it's going to be. It's going to find the right place. So with direct laryngoscopy, this grade 1 view is what we always want to try and find. With video, however, we're looking for this grade 2 view. It's a little bit further back, a little bit less visible, but what it allows us to do is as we advance that tube, it's going to curve down first because of the angle of the blade, and then as it reaches a certain point, because it's plastic and curved, it's going to curve up. People that fail with direct laryngoscopy or with video laryngoscopy get this view here. They see it all and they're like, I had the perfect view of an esophageal intubation. That's what happens. You're in too deep, and in that case, just back out just a little bit, and you aim for this view here. This grade 2 view is the perfect view for video. It's a different technique, and a lot of us can't wrap our mind around it, but it is a different view. Next is the first pass bougie technique. Bougie goes in first, and the tube gets threaded over. Keep that stiffing position, and keep that blade inserted. You go in, you put your bougie in, you sink your bougie in, have your partner take that tube and slide it over the top. Because if you pull that blade out and you let the head relax, we now have a 90-degree angle again. So as you put that tube, you just have to make that corner. Because if you're putting that straight through, it's a whole lot easier. Now then we have the D-grip bougie technique. And the D-grip bougie, the bougie is preloaded. It doesn't require a second assistant. And you pass the bougie, and you put the tube in right behind it. So providers who use a bougie on first attempt consistently have 80% higher first pass success rates. Those are the metrics. If you're not using a bougie, start using a bougie. And then we have the Olde Stylette. There's two ways to kind of mold it. One is the straight to cuff. You may hear this called a hockey stick. A lot of providers were taught this way initially. And the other common practice is an arcuate formation where the tube naturally comes curved and the stylette matches that curve because that was molded for airway anatomy. No one's really better than the other. It's really just preference. Then we have our King Vision here, and that's what we currently use, and that's right there perfect view of an esophageal intubation.